Today we are going to talk about thumb injuries, practical radiological approach. This is my agenda today. We'll look rapidly about the anatomy overview, the imaging strategy, the injuries pattern, and reporting tips. Before we start, we should ask ourselves why thumb matters. Thumb is responsible for about 50 to 40% of the hand functions, especially the grip and pinch. This paper was published in 2002 by an orthopedic department in Texas. He started with this quote for John Napier, who is a Scottish scientist who lived in the 16th century. He said that hand without thumb is the worst nothing but an animated spatula, and at best a pair of forceps without points don't made properly. Okay. As any part of the musculoskeletal system, we should look for the components of the thumb. It composed of three important bones. The first metacarpal bone, proximal and distal phalanges, composed of three important joints: the carbo-metacarpal joints, the metacarpophalangeal joint, and the interphalangeal joints. It has tendons like the flexor and extensor pulsus tendons, and ulnar and collateral ligaments, and the volar, and also the volar plate. Before going to the imaging strategy, we should interpret the mode of trauma of the patient. Most of the patients usually fall on their outstretched hands, or in sport trauma, or in a hyperabduction trauma. The imaging algorithm for the thumb is built on the shoulders of the American College of Radiology recommendations for imaging of hand and wrist injuries, which was published in 2018. It divides the patients into 7 variants, recommending the appropriate imaging tool and mentioning their level of radiation exposure. Its main idea is to start with the X-ray first, go for CT if you suspect fractures, go for MRI and ultrasound if you suspect soft tissue trauma. The radiological evaluation of the thumb injuries will follow a systematic algorithm, prioritizing the clinical history to guide imaging selection. Initially start with plain radiographs, which usually is sufficient in most cases, but you can go to an advanced modality like CT, MR, or MRI, but usually try to minimize the radiation exposure. Our first step is taking history and making good examination to assess the deformities, swellings, the tender points, the stability and instability of the thumb. Then we should attend if there is an open wound or high energy trauma. First of all, start with plain X-ray in usual positions, anteroposterior, lateral, oblique views, or sometimes we need stress views if ligamentous injury is suspected. Then detect the fractures, if like Bennett fracture or Landus fractures, avulsion dislocations. The X-ray is usually sensitive up to 80 to 90% in acute fractures. When to proceed to further evaluation if the X-ray is normal but the patient is still complaining. If we suspect a fracture, go for X-ray. If you don't suspect a fracture and suspect soft tissue injury, you can go for ultrasound MRI. If you find the fracture in the plain X-ray, you can follow up in 1 or 2 weeks, but if the patient you can find displaced or interarticular fracture, go for CT and do reformatted images. If you suspect ligamentous or tendinous injury, you can start with plain X-ray to exclude avulsion fracture. If there is no avulsion fractures, you can go to start by ultrasound, which is cheap and available and give you a dynamic range of examination without exposure to radiation. If symptom persists, you can go for MRI. In complex and in high energy trauma, you can go for X-ray and CT scan, and also angiography if you can suspect there is vascular imaging. If there is no obvious fractures and you suspect also soft tissue traumas, go for ultrasound and MRI. The common injury patterns. The distal phalanx fractures, you can see the tuft fracture, which is break in the distal tip bony fractures into multiple bony fragments. This type of fractures usually seen in door slamming on the thumb. Seminal fracture is seen in adolescent and a child before the closure of the epiphysis, and here we can see there's a small fracture in the epiphysis of the distal phalanx. The proximal phalanx fractures, which can be intra-articular, reaching the articular surface, or extra-articular, limited to the shaft of the bone. The metacarpal bone fractures, which is an important fracture, like Bennett fracture. Bennett fracture is an intra-articular fracture, and it is usually composed of two pieces of bones only. And it should be differentiated from Rolando fractures, which is a similar one, and sometimes it is called the Y-shaped fracture. It is where the bone is divided intra-articular fracture in more than two pieces, and some call it a comminuted Bennett fracture. And we should differentiate between both of them because each of them has a special mode of treatment. And this is a metacarpal bone fracture, which is called epibasal fracture or pseudo-Bennett fracture. The bone is divided into two fragments, but it doesn't reach the articular surface. It's an extra-articular fracture. While assessing the fractures in the thumb, don't miss the presence of sesamoid bones, which are normal variants, and they are fracture mimics, but not fractures. The gamekeeper thumb, which is also known as the skier thumb or breakdancer thumb, it is a avulsion fracture or avulsion and rupture of the ulnar collateral ligament, which may be associated with avulsion in a bone. Here we can see the avulsed bony fragment. This is in the MRI, and this is in the ultrasound. Steiner lesion, which is subtype of the gamekeeper fracture, but it differs that there is the adductor pollicis aponeurosis interpositioned between the joint and the ulnar collateral ligament. It has a very special characteristic appearance in the MRI, which is called yo-yo on a string sign. This is the displaced ulnar collateral ligament, and this is the aponeurosis of the abductor pollicis. This is a case of radial collateral ligament injury. Here we can see the avulsed bony fragment, and this is the ligament. This is a case of volar plate injury associated with a small avulsion fracture. In ultrasound, this is the normal side, and this is the abnormal side. This is a avulsion fracture, and the volar plate is not seen in its normal anatomical site. This is a case of extensor pollicis longus injury, giving a small deformity in the finger, which is called mallet finger, and this is the defect filled with fluid, and in the ultrasound, this is the defect associated with collection. This is a case of flexor pollicis tendon injury. This is the tendon, this is the defect. Also, we can see the defect. Also, we can sometimes see dislocations in the joint, and this is a case of dislocated metacarpopharyngeal joint. And this is a case of dislocated carbo-metacarpal joints, which is usually missed in multiple cases. In reporting, if reporting a fracture, you should mention the site, mention if it is associated with displacement or not, and if it is extended to the joint or not. If you are reporting ligament injury, you should mention the type of the tear and if there is retraction or not. To summarize, this is the algorithm. Clinical assessment, go for plain X-ray. If you still suspecting bony injury, go for the CT. If you're suspecting soft tissue injury, start with ultrasound, which gives you a dynamic range of study and which is with no radiation exposure. If you're still suspecting or clinically the patient is still complaining, go for MRI. The take-home message, X-ray is mandatory, but sometimes maybe it is insufficient. In ligamentous injury, think in ultrasound and MRI. Usually remember that Bennett fracture is not equal to Orlando fracture. They have different mode of management, and the prognosis also is different. Fracture is not the matter, but the matter is to describe the stability, the displacement, the articular involvement, and don't miss extensor lesions, because the aponeurosis, which is seen between the joint and the retracted ligament, will prevent the healing if it is present. Correct imaging with correct wording and reporting will lead to correct treatment. And thank you very much.